One member of the group hosting today's dialogue, the Media Task Force of the Eastern and Southern Africa Interagency Working Group for Risk Communication and Community Engagement. My co-moderator is Tole Nyata, an Internews pandemic mentor based in Nairobi. On the 5th of May, the WHO declared that COVID-19 was no longer a public health emergency of international concern, a PHEIC. It is still considered, though, to be a public health emergency, a PHE, but what difference does that mean to healthcare systems in East and Southern Africa? Why are people in the region assuming now that COVID-19 is over when it clearly is not? This is what we're focusing on today. In addition, on May 11th, WHO declared the Mpox virus, formerly known as monkeypox, is no longer a public health emergency of international concern. Okay, so these announcements have raised hopes that both COVID and Mpox are no longer a threat, but as the talk about these viruses transitions from pandemic to potentially endemic, we have several terms and classifications, but so far, not so much clarity. That's why we're gathering today. We're going to hear from experts to look at the impact these announcements are having in the East and Southern Africa region. And we have several experts lined up to talk about this. We urge everyone on this call to type in your questions in the Zoom chat box, and Tole will ask those questions of our speakers during this hour. So to begin, let's hear from Elsa Maria Karam. She's a social listening analyst at the WHO Regional Emergency Hub in Nairobi. She's going to talk to us about how the public is understanding, perhaps misunderstanding, the status changes of COVID-19 and Mpox. Elsa, welcome back to the dialogue.
Thank you, Wayne. Let me share my screen then. So journalists on the call and colleagues, as Wayne said, my name is Elsa Maria Karam, and I'm a social listening analyst based in the Nairobi Regional Hub with WHO. I'll be able to share social listening overview from my monitoring during the month of May regarding what WHO declared. So as I'm sharing my slide, colleagues, I want to highlight both what are the public reactions towards COVID-19 no longer being a PHEIC, a public health emergency of international concern, and the monkeypox as well. So not sure if, okay, here we go, perfect. So let's start with COVID-19 and basically highlighting that the news about COVID-19 no longer being a PHEIC has gained the attention of a lot of users, mainly private users, anti-vax groups, disinformation groups, local news channels, and international news channels as well. So this has been really interesting to monitor. Over 81.4 interactions on article, as we can see from the graph here, colleagues, and over 3.1K articles published, as we can see during the period from May 4 till May 18th. So while monitoring all of these informations and all of what people are saying, various misinformation and conspiracy theories, including claims that the virus is a hoax, vaccines are ineffective and harmful, and that the pandemic is part of a globalist plot to implement a new world order, have resurfaced. It's very important here to highlight from my end that in every social media post, there were a lot of misinformation in the same post. So it was really flooding in the real term, in the real sense, and a lot has been, taken in, as we can see here through the graph. A lot of articles, a lot of interactions. So yeah, a lot of interactions. So while the emergency phase of COVID-19 is no longer of international concern, and I'll let my colleagues talk more and further about that later on, the threat is still ongoing worldwide, and there's no predictability of the emergence of the new subvariant infections. So we're still keeping an eye on what's going to happen in the upcoming time to go. When it comes to the social listening overview of Mpox no longer being a FEAC, we'll notice a difference here, colleagues and journalists. So as we can see, the public interest has peaked only when after the international, so after WHO declared Mpox no longer being a FEAC, and then dropped drastically after that with no more interactions. So 49 articles have been published all over, and 713 interactions monitored throughout May 4th to May 18th, the same period of time as COVID. So, as I said, the level of engagement on Mpox and on all social media posts has been low compared to other global regions and other disease outbreaks in Africa. Online users claim that Mpox wasn't a FEAC from the start, that big pharmaceutical companies profit from monkeypox outbreaks around the world, and demanded to defund the WHO. So these were the main kind of highlights that I want to share with you. And finally, that the dissemination of dis and misinformation extended beyond the comments on posts shared by international news agencies, but similarly targeted public health experts. So talking about the Director General, Dr. Tedros. Yeah, this is it from my social listening side or overview. Back to you, Wayne.
Thank you so much, Elsa. That's a lot of interesting information and a lot of misconceptions about what is going on. And we'll dig into that further in this hour. Before we go to any questions, I want us to hear from our next speaker. Dr. Michael Muteba is a public health specialist with more than 10 years experience in the global health sector. His areas of expertise include disease surveillance and outbreak investigation, emergency response, and public health coordination. Dr. Muteba joins us to explain the differences between PHEIC and PHE, between pandemic and endemic, what these classifications mean to us and to journalists who need to explain all of this to their audiences. Dr. Muteba, welcome to the dialogue.
Thank you very much, Wayne, and good afternoon to all our listeners. All right, so I'm going quickly, first of all, to remind all of us, what we know about COVID-19. So the first case of COVID-19 was reported to WHO on the 31st of December, 2019. And this marked the beginning of the COVID-19 outbreak, which has since spread globally and resulted in a pandemic. And on the 30th of January, 2020, the Director General of WHO, Dr. Tedros, declared that COVID-19 was a public health emergency of international concern. And this declaration actually was based on the advice that he received from the emergency committee that convened under the International Health Regulation from 2005, which is the global legal framework for responding to public health emergencies. And they looked at the evidence of sustained human-to-human transmission, meaning that the virus was spreading between people and not solely within or solely from animals. And then they also looked at the increasing number of countries that were reporting COVID-19 international spread. They also looked at the severity and the impact of COVID-19. There was an assessment that was done on that, and the public health response capacity. And without forgetting that there was also a necessity for international cooperation or coordination to prevent further international spread. But just after that, on the 11th of March 2020, WHO declared that COVID-19 was a pandemic. And here I want to maybe look at the importance of maybe explaining to our listeners why after being declared a public health emergency of international concern, it was then declared to be a pandemic, because the criteria that was used is different, but it doesn't mean that a pandemic is more important than public health emergency of international concern. Because the criteria that were used for WHO to declare that COVID-19 pandemic was a pandemic were based on the geographical spread. A disease must have spread to multiple countries and continents, and this is very important. They also looked at the severity. The assessment of the disease impact then showed that the outcomes were severe in terms of ICU admissions or hospital admissions. The health system were strained, and then the mortality rate was also very, very high when we looked at the case fatality ratio. And then they also looked at the impact on the society, as well as the ability that countries had to control or mitigate the spread. And then just a few years later, I'll say probably 3, Director General Dr. Tedros now declared that the public health emergency of international concern status of COVID-19 was lifted. What does it mean? So, the lifting here was also, again, advised by the emergency committee, but it was established that COVID-19 has established itself as an ongoing health issue. So therefore, looking at the criteria that were used to declare COVID-19 as a public health emergency of international concern, especially the first one, which says that a disease or an event should be an extraordinary event, which COVID-19 was not anymore. And then looking also at public health risk on other states or other countries, or looking at international spread, it was not news anymore. And the requirement for international coordination. So they looked at those and then decided to lift the status of COVID-19 as a public health emergency of international concern. And now here, I just want to bring in some important concept, because people want now to know, are we moving into an endemic phase of COVID-19? No, I think we have to understand that when we talk about pandemics, you can have a pre-pandemic phase, then you have a pandemic phase, then you're going to have a transition phase. And after the transition phase, you are going to have a post-pandemic phase. But just to talk about the differences that we make between an endemic and a pandemic, it's just in terms of, when we look at the definition in terms of the presence. In a pandemic, we have a global spread of a disease, while in an endemic, there is a constant presence of a disease, and it's a routine health issue. But also in an endemic, you have cases that remain stable over time. And there is a persistence of that disease over an extended period of time. But while in a pandemic, it can start and then it can end. We had pandemics before, the Spanish flu, the avian influenza, even at some point, HIV/AIDS, which is still now, for some it's still a pandemic, and for some, they can also call it an endemic. So for now, I think we are still in the transition phase, and we should not confuse terms here. And we are working now toward the integration of COVID-19 surveillance into routine health systems, health surveillance systems in countries. I think I'm going to stop here, and if our listeners have questions, we'll be able to answer. Thank you very much. Over to you.
Thank you, Dr. Mateba. Tole, do you have some questions for either Dr. Mateba or for Elsa?
Yes, I have a question for Dr. Mateba. Joseph Roby from Kenya is asking. So I have like 3 questions which are similar. So Joseph Roby asks, what has WHO done to make sure we don't have a COVID-19 like situation again, especially in the third world countries? And then we have Agnes Mwangangi, who is asking, how prepared is WHO in case of another pandemic breakout? And the third question, which is similar, is what steps should the world take to be better prepared for the next pandemic? Thank you.
All right. Thank you very much for those questions. Actually, they're similar because they talk here about preparedness, first of all, of what the WHO has done. I think the World Health Organization has really invested so much resources into capacity building, first of all, in different countries, in the member states, in terms of incident management systems and teams that were deployed, and people were trained in almost all the countries around the world, because this was a novel virus and another situation, and especially for our generation to have such a pandemic. So WHO has invested a lot. And when you look at the incident management system, what it looks at is how to coordinate, the response to COVID-19 together with different stakeholders, different partners, technical partners, or even financial partners, but also putting in place public health emergency operation centers where data is going to be collected, analysis will be done, and the decisions are going to be made. And of course, I think with this pandemic, WHO has also invested a lot in the risk communication and community engagement. And today, when we were listening actually to Elsa, I think she's just one of them. We're working on information, collecting information, but this has gone to different countries, but also supporting the vaccination. So these are things that WHO has done to control the COVID-19 and to bring it where we are today. Because without what WHO has done, together with the help of other health partners, actually, I wanted to mention there is a document that was published some time ago by the World Bank. And it was stating that if those efforts were not put in place, the number of deaths and even casualties that would have probably be 10 times more, or 10-fold more. So I think WHO has done a lot. And now, in terms of things that have been put in place to avoid that this occurs again in Africa, I want to mention here that enhancing the detection of novel virus is quite important, and that's why there is this strategy and this approach of genomic surveillance that has been done to enhance laboratories in all the African countries. WHO supported the purchase of new equipment for the genomic sequencing to be done and genomic surveillance to be done. But you are also going to have countries that are also pushing with wastewater surveillance. I think it's very important that we keep on doing the surveillance, monitoring whatever that is happening, so that as soon as there is any threat that is detected, a response is actually done as fast as possible. I think I'm going to stop here. I think I put all those three questions together and answer them. Thank you.
Thank you, Wayne.
Okay, excellent. Okay, so that's, we've talked about COVID-19. Now let's talk about Mpox, which has also been regraded. But does that mean we are out of the woods with this viral illness? To talk to us about that, we have Dr. Felix Sani. He is a WHO epidemiologist and health data scientist based in Brazzaville. His expertise cuts across public health emergency management, epidemiology, economics, and business sectors across the globe. Dr. Sani, welcome back to the Media Dialogue.
Thank you. I'm happy to be here again. I will quickly talk about Mpox and the limited time available. And I want you to know that in the case of Mpox, it's a bit different from COVID-19 because of, let me say, the lower number of cases and the deaths, particularly the case fatality rate. Or let me quickly give an overview of what the situation is globally. As of this week, over 87,000 cases have been reported globally. Let me just say 87,730 cases with 143 deaths. So the case fatality rate is just 0.2%. And mostly coming from the region of Americas, as reported 67.7% of the total number of cases reported globally. European region has reported close to 30%. Africa, where the disease was initially endemic, has just accounted for just 2% of the cases. So in Africa altogether, 13 countries have reported cases in this outbreak since it started in 2022. And most of these countries are coming from the Central and the Western Africa, the Southern and the Eastern Africa are not just common, apart when you're looking at the South Africa and then thinking Mozambique. And also with the response to monkeypox, which is also known as Mpox globally, let me say first that on the July 23, 2022, it was declared a public health event of international concern because of the international outbreak. So many countries were involved, including 111 countries in all the 6 WHO regions. And but due to the response in October 2022, the cases started declining up to the present moment. But I want to say, looking at the overall case, monkeypox cases, the monkeypox is well known in other parts of the continent or other regions to be associated with men that have sex with men. Over 80% of men that have sex with men were reported having a Mpox. Also, the HIV and other immune compromised people, over 50% of them are affected with the disease. Also, travel history was around 16%. That was the major reason it was declared a public health event of international concern. So let's look at the Africa. As I said earlier, the 13 countries reporting Mpox in Africa include 10 countries from the Afro region, that is WHO Africa Regional Office. And there are 2 major clades of Mpox. One is known within Africa, which is a clade 1, that is very common to the Central Africa, and the Western Africa, which is clade 2. This clade 2 is the one circulating, and which is a little bit with a lower CFR compared to the clade 1. So due to the decrease and the decrease in number of cases and the low CFR, and due to the intervention, then the cases are stable across the globe. And sometimes we witness a surge in some cases, particularly in Africa, then in a country like Mexico and Japan, which are currently recording cases. So globally, the cases are decreasing. Then on the 11th of May, 2023, it was declared no more a public health event of international concern. Notwithstanding, there are still concerns that we need to look at when it comes to Mpox, particularly in Africa. So let me state some of the reasons why we witnessed a significant decrease. One of them is the increase on intense on risk communication and the community engagement. Then there's an increase in immunity due to vaccination in some areas, which is not common in Africa. Also, introduction of new measures, or sometimes it was publicly known that the tecovirimat, which is meant for smallpox, is also effective in treating Mpox. Also, surveillance was also increased. Notwithstanding, if it is no more a fake, there are still other conditions. For example, in Africa, we have vulnerable children, we have the pregnant women, and we have people with immunocompromised conditions. For example, in DRC and in Nigeria, Also, recently, we witnessed a number of cases in the past 2 weeks in Cameroon. Cameroon has reported about 11 cases, whereas they have not reported cases since October 2022. Also, another reason why this is still a very serious issue, particularly in Africa, is the limited progress, limited knowledge of the historical transmission. In Africa, we have been struggling to characterize and understand the mode of transmission of Mpox, but we have not been able to do that. And one of the challenges we are facing is limited resources, unlike COVID-19, where we have a lot of resources. For Monkeypox, altogether in Afro for 2022 to now, less than $1 million was available, so which is very weak, which is very small to strengthen the investigation, research, to better understand the situation and to control. Also, the treatment of Mpox is limited in Africa. Most countries don't have vaccines. And also, we have limited information, as I said earlier, no data for analysis, also weak laboratory capacity, particularly in DRC. Let me mention that the DRC reporting a lot of suspected cases with limited ability to test. Altogether, they have reported less than 800 cases since 2022 till now. Notwithstanding, in only 2023, the DRC has reported over 3,000 suspected cases with 175 deaths. So the CFR is very high, which is high above the WHO recommended recommendation of recommended value of 1.0. See, currently the CFR is fluctuating between 5.0 and 8.0 in DRC. Also, to conclude, one of those reasons that this Mpox is still a very public health of emergency is that there is possibility of a clade-1 circulating, which is well known within the Africa, particularly the cross-border effect. For example, recently in March, somebody traveled from Germany to DRC, and getting to DRC, he infected 6 other people, and from the 6 people, 2 people died, which is the first laboratory confirmed death reported from the DRC. Or there's possibility that the cases there might be cross-border transmission. Also, the low capacity for countries for detection and the confirmation of the Mpox is another challenge that may still allow the disease to spread. Also, there is urgent need to integrate Mpox in the existing program across countries. So the level at which countries respond to Mpox is limited compared to COVID-19, because in most places they don't consider it as a public health event of international concern. They believe that it is endemic, and because the case fatality ratio is low, no enough investment, and it is considered a lesser disease compared to other diseases. Also, Mpox is happening in Africa amidst other multiple outbreaks, over 105 outbreaks in Africa, and some of them, for example, cholera, looking at Marburg and other things. So attentions are more focused on the others ones than the Mpox. So in conclusion, Mpox is still a public health event of concern, and more attention is needed and we are advocating with country and member states to develop strategy and strengthen surveillance to come and control the outbreak. Thank you. It's over from my side.
Thank you very much, Dr. Sani. Tole, do you have questions for Dr. Sani?
Yes, I do. So someone is asking, what is the difference between Mpox and Monkeypox? And then another question is, what are the symptoms of Mpox? And the third one is, how long do Mpox symptoms last? I have more, but we'll take those 3 for now. Thank you.
Okay, thank you very much. let me respond starting from the first one, that what is the difference between monkeypox and Mpox? Mpox and monkeypox, we are still referring to the same thing. But last year, around December last year, it was agreed during the emergency meeting that monkeypox, due to the stigmatization attached to monkeypox, the name should change so that it will not be limited to some people, or that the people infected are being called monkeys and a few of that, due to popular impression that it's very common where monkeys are very common. So it was agreed that the monkeypox should be renamed as Mpox, and it was globally accepted. Notwithstanding, it is still allowed in January 2024 that you should be calling it monkeypox at the same time Mpox. But as at some point, it is agreed that when you are introducing in any writing Mpox to be introduced, it should first of all be called monkeypox, then put in bracket Mpox. Then subsequently, it should be referred to as Mpox. So when you're talking about the symptoms of monkeypox, the most common symptom of monkeypox is rash, and it usually lasts from 2 to 4 weeks. And other symptoms include a fever, headache, muscle aches, back pain, low energy, swollen gland, that we also call lymph nodes, and the sores, or the series of sometimes the source may be in the hands or the palms of the hands, or may be at source of the feet, groin, and a few other ones like that. So those are the common symptoms of Mpox. And the incubation period is between 7 to 21 days. But sometimes it lasts between 2 to 4 weeks. Sometimes it is on its own when it is not a chronic condition. So, but the majority of deaths reported with Mpox are coming from the people with immune compromised, the HIV, those that have sexually transmission diseases. I don't know whether I answer all the questions correctly, or there's any other question that I've not addressed. Thank you.
Thank you, Dr. Felix. I have more questions, but they'll come later. Wayne, back to you.
Okay, great. Thank you, Tole and Dr. Sani. Okay, so we've heard that Mpox and COVID are public health emergencies of concern, but no longer of international concern. And we also know, we're on the road from having pandemics to eventually endemics. A lot of terminology. As journalists, how do we report on this, and how do we make sure that our readers and viewers and listeners still understand that these diseases are still with us and are still causing all kinds of problems? And to help us sort through all of that, we're joined by Ida Just. Ida is an Intranews Global Health Advisor. She's going to talk to us about, give us some ideas on how journalists can approach these very complicated issues. Ida, welcome to the dialogue.
Thank you, Wade, and hi, everybody. That was really fascinating information from Elsa and from Dr. Muteba and Dr. Felix. I really appreciate that a lot. I just wanted to actually point out all these news headlines behind me. I've been gathering them over the past 3 years of the pandemic. And when the public health emergency of international concern status was lifted, like friends were asking me, and I was asking myself, should I lift the posters? And I thought, no, because I know COVID is not over, and we should have a reminder of that. I want to have that reminder every day. I'm a journalist. I'm with Internews, and we work with journalists, to help tell a variety of health science stories. So I didn't lift it because it's not over, as Dr. Muteba and others have said, and also because the reminder is important, but there are more sustainable and more subtle ways to tell that story. So I thought I'd focus this on what are the subtle ways to communicate what Dr. Muteba has said, what Dr. Felix has explained to us about Mpox as well, and also what the social listening tells us about the perceptions are there. It's clear that we can't just stop reporting on COVID-19, but we do need to find new ways to report on it, because that status change, it doesn't mean nothing, it means something. So I thought, the IC in PHEIC has disappeared. So I think that's a sort of a thing that we can go to. I've just put up 5 very simple tips. There could be 10, there could be 3, but I thought 5 is a good number to remember. And I hope that if you stick to those 5, that the science will still be accurate and you'll still be relevant to your audiences. So obviously, as journalists, we speak to our readers, we speak to the people who watch our videos, who follow us on Facebook, who read our articles. And with the international designation being lifted, I think it's ever more important to think of what is the story and what are the questions. If you think of what Elsa spoke about, the social listening, that's all about questions, misperceptions, fears, and so on. What are those in your very own setting? We all, as journalists, have a good idea of who our audience is. Is it the entire country? Is it a certain town? Is it a region? So we need to be in tune with what those questions are, the rumors or the misperceptions in the audience that we write for. So in other words, what is the buzz about COVID-19 and about Mpox? Is the buzz that it was never a thing, or now we have to stop thinking about it? Is it that there's huge concern? For instance, if you're living in Kisumu in Kenya at the moment, you would know that there is a COVID-19 outbreak, and COVID-19 has been picked up in several schools. If you're living in China, you will know that there is a concern that there may be something like up to 65 million new cases per week. Wherever you live, I think all of the scientists on the call will agree there's too little testing and there's too little knowledge of new cases, and they're always asymptomatic cases. And that can always mean that this pathogen can spread again like it has done before. Thankfully, vaccines has made that less of a threat than in the past, but it's always a possibility. So I think one thing, rule number 1 or tip number 1 is be relevant for your audience. Find out what it is that they are asking about and talking about. And that's one of the golden rules for any journalism. What does my audience want to know? I give them that information. But secondly, also, we need to know what is the data. So that's another way of being relevant to our audiences. If the data is poor because there's been no testing or there's no communication about the data, it doesn't mean we step back. If the data suggests that really spread is low in the place where you live, yes, then it's a time to think of more innovative stories and more long-term stories, which I'll get to in the other tips for the moment. But the point is, you do have to know whether there are whether new cases or incidents is a concern, and also need to know what the sort of population spread or the prevalence is of any pathogen. As a health journalist, we need to know that about any pathogen that exists where we live and where for the audiences we write for. Okay, so let's go to tip number 2. Tip number 2 to me is almost the most important one, because we live in a part of the world where HIV has never stopped to be a problem. We may not see those dying bodies. Some of you might be old enough to remember. I'm old enough to remember when people were getting thin and were dying when they were HIV positive. It's a completely different epidemic now. But at some point, HIV was a pandemic health emergency of international concern. It no longer is. It has not stopped to be a story. And that's the way that we can start thinking about COVID-19 and can also think about Mpox. Think of malaria. Malaria is a huge killer on our continent. Is it not a story because it's not a public health emergency of international concern? Of course not. It's a huge story. It's a story that all health journalists should pay a big amount of attention to. So I'm trying to suggest that just because this designation has been lifted, in no way means that it is not a story. It simply means, as Dr. Muteba has explained, that the response effort is different. It no longer requires this massive international coordination. But in your village, in your city, in your country, in your hospital, and just even it doesn't always have to be one's own family or village, but it's just the fact that malaria has not been eradicated despite the tools existing. That's all a really big story and must remain a story. I don't know if we have time for that, but please, everybody, just think for a moment about what other diseases are there that are not a public health emergency of international concern, that long name, but which is a really big issue. I mean, the first one that jumps to mind for me is cholera. We've had so many cholera outbreaks, serious cholera outbreaks on the continent in the past months. In Malawi, it's lasted for months, which is really unheard of for cholera. So it means something there is not being solved, whether it is on the biomedical side or the behavioral side. There's a huge concern. I live in South Africa. We now have an outbreak in 2 parts of South Africa that have also lasted longer than they normally last, and people have died. So think about other issues which don't have this designation, but which are clearly a health story that we should keep writing about. So, and then we start to see that in a way. I'm not saying we normalize COVID or Mpox, but we realize that it just doesn't stop being a story. So let's go to the next tip. I think any journalist who's lived through this pandemic, and that's all of us, have to have a kind of checklist handy, because at any time we could hear, in the same way that we heard about COVID-19, that there's a new pathogen that might have pandemic potential. We've been hearing about bird flu. We got a big fright when Marburg broke out in Tanzania. And of course, it may be a disease or a virus that we hadn't heard, that we've never heard about. So I think any journalist who's been through the pandemic, we owe it to ourselves to actually know, just in an instant, what will I do if I hear about such a pathogen? Who will I contact? Who is that expert that I've built a relationship over these 3 years of the pandemic, who can kind of help, can explain it to me? It shouldn't be like just over 3 years ago when we were all in a panic and thought, I don't know an epidemiologist, I don't know a virologist, where shall I start? It can't be like that. If it is like that, we have to change that, because we all talk about lessons learned, and that is a big lesson learned, is who do I contact? Where is the credible information? I think we also need to think about what will we tell our editors. Many of us have to answer to editors. Very often editors are not steeped in health and science reporting in the way that people on this call are. And those editors will say, oh, come on, it's not real. Where do you hear this from? Or the editor may think, oh, this is a huge emergency, it's a panic, when it actually isn't. So in fact, we need to be that sort of trusted voice in our newsroom or amongst editors or the people we write with or write for, because we've been through the pandemic. And if you're on this call, you're interested enough in health and science to be that expert voice. Think of what you would say to that editor. Is it that we should step back and first just find out if it's real? Should it be that a really trusted expert has given you a tip that this is something to watch? Whatever it is, have something handy to say to your editor. And then also, there could be a moment, again, like it was with COVID-19, when those images start to be forwarded to us again, when fake images or just concern or genuine questions just come across our social media posts or come across the conversations that we have in our homes. And that's a moment to take a deep breath and remember, and I will never forget what it was like in the first months of the pandemic, when there was just such a flurry of panicky information. We should just realize that, hold on, take a deep breath, take those lessons learned of the time at the height of misinformation, and try to discern. Remember what we were teaching ourselves about how to differentiate between gossip or rumor or fear. And I think we owe it to ourselves, if such a moment should ever happen today to us. It can happen. That's how it happened with COVID, that we should be prepared for that, for day 1, day 2, to not make some of the same mistakes, and actually once again be a sort of a beacon of science and a beacon of good information for those around us. And the next slide, or the 4th tip, also has to do with preparation. So we can go to tip number 4. You will have noticed that about this buzzword, preparedness and response. So I think, in the health community, I mean, those are important. It's a buzzword because it's important, but we need to know what it means for us as journalists. So we've heard this phrase, I'm sure you've heard it, that an end to this emergency phase brings focus to preparedness and response efforts for future health threats. This is what Dr. Muteba was also talking about. We hear that the world must take action on lessons learned to prepare for the next disease. So what does that mean for journalists? Journalists are part of the response, are part of the whole chain of information that needs to go right, to be sure that people know what to do, to be sure that people don't panic and that they understand what the threat is that is at hand. One is we must always sharpen our science literacy as journalists. I think we all can agree that many journalists who hadn't covered science before discovered the beauty of science, discovered that science is full of uncertainty. The uncertainty principle in science is not to do with doubting what scientists who are working in established science, what they have to say, but it's understanding what they mean when they say, we don't yet know. We don't yet know if there will be a vaccine. We don't yet know how this virus spreads, for example. That is a very important principle in science, and that's almost one of the most important elements of science literacy that I think is a lesson learned for us as journalists. We must maintain on the COVID-19 contacts that we've built. We have all built COVID contacts in this time. We know more epidemiologists than before, or we've met an epidemiologist for the first time, whatever the case may be. Build on those contacts, because as we've seen with COVID, it's the experts who've known how to respond to HIV and to Ebola who now have known how to respond to COVID-19, because the scientific and the response principles are the same. And then we must definitely, because journalists are concerned about human rights and about access. So in other words, we must also explore and expose all of those issues that have to do with equity. For instance, how are we prepared for the years ahead? In the past, it's been said that our continent does not have enough capacity to manufacture vaccines. Now there have been some developments. We must actually be sure that we know the story. What's happening in Rwanda? What is happening in Cape Town? There are countries, there have been positive steps, but we must know that story so that when the next pathogen hits us, disease X, as it is called, we know that we can phone up that lab, or we have a contact there and say, hold on, would you be set up to actually be part of the manufacture of a new vaccine for this new pathogen? You on the left, you see I said, what is disease X? I wonder, maybe we have enough time to ask, what is disease X? Does anybody on the call, any journalist, want to tell me what disease X is? What does it mean? Have you heard the term? I'm sorry, I was talking so fast. I should have taken a breather before and asked a question like this. But does somebody, Tole, is there somebody who wants to answer the question?
So far, no one.
Okay. I think we can guess, right? So X normally kind of is, of course, what we use when we sort of say unknown, the thing that is not yet named, that isn't yet known, but it's perhaps known that that thing will come. And that is what scientists use to describe the fact that we can be almost absolutely certain that there will be another pathogen that will become a pandemic, or that will become a huge threat, or perhaps an outbreak or epidemics in parts of the world. And it's called disease X because perhaps it's a virus, just like SARS-CoV-2 had been, that does not yet exist. It can be a virus that already exists, but for some reason spreads in a similar way to the way SARS-CoV-2 has spread. But it's called disease X because it is known that the conditions for the fast spread of a new virus are such that there is likely to be another one like SARS-CoV-2. So it means it doesn't yet have a name, but it will happen. And that means we know that we need to be prepared. So once that new pathogen comes, we just slot in the new name. We have to slot in how that virus works. How does it spread? How virulent is it? How fast does it spread? What kind of disease does it cause? But a lot of the rest of the stuff is actually the same, is that we must only take information from trusted sources, that we have to take a deep breath and take it all in before spreading information that we're not sure of, that we've not verified. So as journalists, that means that, and that I've put in, we must also activate our fake news detection radar. That is something that all of us, we've exercised those muscles during COVID-19 because there was so much false information. And I think I want to speak for myself. I definitely got better at detecting when something looks too good to be true or too bad to be true. So that for me is an important one about preparing for the years ahead. That is tip number 4. And the last tip is a very simple one. And that tip number 5 on the next slide, please, is just to say we must take our watchdog role seriously. There's a term called watchdog journalism, but I actually think it's a bit of a nonsense term because to be a journalist is to be a watchdog. So that's sort of like the two together just really makes it clear what we're supposed to be doing. Just yesterday, the World Health Assembly ended. There were a lot of global agreements, new commitments, a new clear call for the fact that, for instance, that member states of the WHO must pay more so that there are fund towards their membership, so that there is sustainable funding for all of these responses that the WHO is responsible for. Those are global agreements. We must keep a watch on the global agreements. But we also, of course, are all a citizen of a certain country. It's important that we know what is our own country promised in terms of how it will build out the health system. What new policies will there be? Will it have a rapid response team if there's a new pathogen? Is our country one of those that has been designated to be part of vaccine manufacture, for example, or genomic surveillance? If so, keep a check on that, keep those initiatives, keep those accountable. And there are also local plans which might not be so much about huge amounts of funding, but just about being aware. Are schools set up for the next outbreak? What about hospitals? There's a lot of discussion these days that masks should be brought back into hospitals because there should be mask wearing still in such settings. There are flu outbreaks. COVID-19 still does spread. What is the hospital doing about it? There's a lot of calling for it. I've spent a lot of time in a hospital in the past week because of a family member who's ill. I saw hardly any masks, and yet, of course, it makes a lot of sense to have masks in hospitals. And then what else would we keep a watch on the next pathogen? So it's the next viral or fungal or bacterial infection that we ought to be watching out for so that we don't go back to where we were 3.5 years or 3 years and some months ago and say, oh my gosh, we haven't learned any lessons. So those are the 5 tips, and I hope they have meaning for you, and tell me if you have questions about them.
Thanks so much, Ida. So I mean, a lot for journalists to contend with, right? Keeping a tab on the current health emergencies and getting ready for the next one that hasn't shown, but we know is coming. Tole, do you have questions for anyone in our group of speakers today?
Yes, I have a number of questions. So in the interest of time, I will read all of them, and then folks can pick the ones that in their area. So Joseph Robbie is asking, has WHO put in place, what has WHO put in place to ensure that when new diseases emerge, the other existing diseases are not ignored? Then we have Anamiti, who asks how to handle mis or disinformation coming from experts, such as medical doctors. For example, some doctors are spreading information, usually when a celebrity dies suddenly, that their deaths are linked to COVID-19 vaccination. As journalists, who is not deemed an expert and a doctor, is regarded as one. How do you tell that story? Also, there is a question on Mpox and pregnancy, which asks, can a fetus be infected by a mother? And also there is another question on COVID-19, on long COVID in particular. What is the latest information about long COVID? And also the final question is on COVID. What is the youngest age one can take a COVID-19 vaccine? And just to remind folks that Internews has a free online course called Let's Talk Vaccine that's available in a number of languages, which can also help you answer some of these questions. Thank you to the panelists.
Okay, anybody who wants to take any of those questions, please, the floor is yours.
Okay, I will start.
Go ahead.
Yes.
All right. I'm going to start with the question that was asked about what WHO has done to prevent, if ever there is a new pandemic, existing diseases are not going to be neglected. I think there is a lot that WHO has been doing and is still pushing together with the help of partners for member states actually to strengthen what we call, the resilience and the recovery, which is definitely very important, because with what has happened, COVID-19, we have learned a lot. And it's quite important that now we build capacities in countries to have what we call the maintenance of essential health services. So no matter what outbreak or epidemic that will come, I think the maintenance of essential health services should definitely always be there and maintain and be optimal. But beside that, there are many, I would say, many initiatives that are there to stay, and I'm going to mention a few of them. First of all, for surveillance, we want what we call under the flagship project. We want to do what to transform the African surveillance system. I think it's very important that the African surveillance system be transformed, because if in the past it did not work, it means that we made mistakes, and then we have learned from those mistakes, and it's time that we transform that. And a good way would be to ask countries to accept what we call the integrated disease surveillance and response. So if we are acting in a way that surveillance is integrated, which is something now we are trying to do with COVID-19, for it to be integrated, for example, to the influenza surveillance system in many countries, but also in the reporting. I'm sure that we are not going to be able, we are not going to start neglecting other diseases, and because we'll be able to detect very, very fast any threat, and we'll be able to act on time. It's when we act with a delay, that's when now, there is panic, and then we lose a lot. But there is also initiatives, from 2022 to 2026 to help countries or member states to develop their own national action plan, for health security, because all those strategies should be in those plans and the national health security plans. So it's quite important to mention that. And I think there are also global vaccine plans. There is also the promotion of the universal health coverage, which will definitely make, I think, at some point, especially for African countries, that we are not going to neglect any disease, even if there is a new outbreak. I think I'll let, first of all, my colleagues to tackle the other questions, and then I'll come back on. I think there was another one on COVID, but I'll come back on that. Thank you.
Okay. Thank
Go
you,
ahead.
Michelle. I'll go for the question related to how to handle misinformation coming from health experts in the field. So as we know from the COVID-19 pandemic, there are a lot of doctors who are kind of in collaboration, let's say, with prominent anti-vax and disinformation groups. Most prominently, I'm sure you have, let's say, seen the Twitter of some of them, or seen disinformation groups. And then I think what's important here, although recognizing their existence, we should check first if that content has been debunked already. We can do that. I'm not sure if you're aware of the Viral Facts Africa, which is a content production of the WHO, and specifically of the IRA, the Africa Endemic Response Alliance, whereby we have debunked an amount of misinfo handled during the COVID-19 pandemic and other outbreaks. So yeah, checking if some claims have been debunked already, that's important first. Second, what we can do as journalists, seeing maybe misinformation from health experts, is to always amplify accurate information from the WHO and checking credible sources like the WHO and seeing what has been posted on current platforms. I think this is important too, as Ida said, as we are watchdogs, journalists, watching what's happening and being critical thinkers, seeing what is the type of information, but still amplifying what's accurate and what we know so far. One other thing that I can think about is, depending on the local context of your countries, is to contact or view what local fact checkers have also done in that context, seeing if there are specific health fact checkers who have also debunked or are in contact with health experts, and trying to see what has been done on that side. So I'm not sure if this answers your question, but from my end, like, what can I think of so far if handling misinfo coming from medical experts? To always check what has been debunked from Viral Facts Africa, amplify current trusted information, and contact local fact checkers. Over.
Okay, please allow me on the same. I'd like to ask Ida this question. It's coming from Lucy. And it says, on the position of journalists in the event of pandemics and cures, do you think journalists should only inform about the disease and the available cures, or do you think they should participate in the to promote cures? Is it a debate among the journalism community?
I love this question, Lucy. It's a fantastic question because, yes, it is a debate in the journalism community. And the reason why it is that journalists pride themselves in not being advocates, not advocating for anything specific, and being neutral and independent. But I think the pandemic really tested that theory in a big way. For instance, I am not in any way, I don't want to say I'm not ashamed. I'm proud to say that I'm very pro-vaccination because I think the science is so compelling that I actually wouldn't be doing my job as a science journalist if I tried to pretend that there's a sort of debate or there are two sides of the story. Some issues are more subtle. And as you've said, I like your question so much, I just want to read it again. Inform, or should they participate in promoting cures? So I think definitely a journalist shouldn't participate in promoting a specific cure with a specific brand name, etc., etc. But a journalist should. It's very subtle. I'm trying to find the way to say that there's a subtle difference between promoting something and being quite clear about what the evidence suggests. And in fact, I actually think it is wrong journalism or irresponsible journalism if the science is settled and that journalist still sort of wants to depict it as a sort of debate or two sides of the story. One of the ways in which I once heard this described, when South Africa had HIV denialism or AIDS denialism in the late 1990s, one of the experts I spoke to said, you can't present it as an equal argument that some believe that HIV causes AIDS and others don't, because it's almost the same as saying, because some people believe the earth is flat and others know that it is round, that the earth becomes elliptical. It isn't elliptical, it is round, and so don't be scared to back good science. Really, it's an important tip. Don't be scared to back good science. But there's a difference between that and promoting a specific cure or being behind a specific pharmaceutical company, or looking like you're shouting down anybody else who doesn't have this information. So it's a really subtle matter. So I hope it's been just hold a second. I hope it's been not too vague, but I just want to say it is a debate, and COVID taught us that there are times to be unambiguous about what good science is. Yeah.
Thank you. And the mic goes back to the doctors. There was a question of
yes.
Mpox and pregnancy, the latest on long COVID, and the youngest age a person should take COVID vaccine.
Yeah, so let me start by complimenting my colleague on what WHO should do so that existing diseases are not neglected. In addition to what he said, let me come from the area of monkeypox. Recently, WHO integrated Mpox as part of the IDSR, which stands for Integrated Disease Surveillance and Response. And there was a guideline developed for countries, which is still in the making, for countries to respond to monkeypox. Also, training and capacity building is one of the essential things. I have already mentioned that earlier, that, for example, in DRC now, DRC has no capacity to test monkeypox, so which shows that less than 20% of suspected cases are being tested. Also, to build capacity is very important to have resources. I said it earlier that resource allocation is important, but less than $1 million has been allocated to the WHO Afro in the past 1 year now. So which shows that there's limited capacity to support the countries. Notwithstanding, WHO has been doing its own within its own limit to support countries. Also, there should be regular awareness. As I said earlier, there should be increased or intensive risk communication and community engagement. Also, other partners should come into play. It shouldn't be only WHO alone that will respond. So, working with other partners, we help to even respond to some of the diseases that have been neglected. Then coming to the issue of monkeypox, so and the pregnancy, I will not say that pregnancy can be transferred, particularly from the mother to the fetus. But due to limited data, so but there are some studies that show that pregnant women are more susceptible to monkeypox, particularly when the human-to-human transmission. Also, there have been studies that have shown that mothers that are infected with monkeypox, when moved close to the children, the newly born baby, the baby can also be infected. Notwithstanding the frequency and the risk factor or severity of adverse frequency in pregnancy is yet unknown. Also, recently there was a publication from the United States, that a pregnant woman gave birth, but the baby was not infected. Whereas there was another study that said out of 4 pregnant women, 2 of them, the children got infected and they had a miscarriage at the second trimester. Notwithstanding, the product of conception were not tested, and it cannot be fully established. So I will not say yes, I will not say no, because there are still more, there's need for more study in this area. And I want you to also note that the WHO is planning extended epidemiological investigation in some countries in Africa now, particularly DRC and Nigeria, where cases have been persistent since 2017. Thank you.
All right. I'll come in now for the question on COVID-19 vaccination in children. So first of all, I want to say here that even medical experts who are advising the World Health Organization, they have, they've done the review, and then they found that COVID-19 vaccination of children with approved vaccines is safe and effective. So it needs to be approved vaccines. So now WHO has approved the Pfizer and Moderna vaccines for children aged 6 months and older. And now for children who are between 5 and 11 years old, there is what is called, pediatric vaccines that they can receive. And for those who are 12 years and older, they can receive the same vaccines that adults are also receiving. So WHO, to answer the question, WHO is recommending to vaccinate children as young as 6 months. But again, it's only once those who are at high risk of developing severe diseases have been vaccinated. Thank you.
There was one, the latest on long COVID.
Okay, so sorry, I didn't get that question. Can you please read it for me?
What is the latest information about long COVID?
Okay, so there is a lot. Actually, there is a lot of information about post-COVID-19 condition, and that's the way we call it, or long COVID. But so the question is a bit vague when someone asks what is the latest, but what I can say, maybe the latest is research continues. Okay, so there are many studies like even WHO is supporting, for example, one where we went recently in Namibia, where we want to look at in the African context or in the Namibian context, what are the factors that can be associated to post-COVID condition. So there were many symptoms already because we had a preliminary data, many signs or many symptoms that could be given. And I don't know if I should go on that side to say that will be the latest, but I think I would say just research is going about post-COVID-19 condition is real, and between 6 and 10% of people who were infected with COVID-19 are developing post-COVID-19 condition. And I think the signs are different. They can vary, from pain, muscles, or arthralgia, or even go to some signs that are affecting the mental health. Okay, you have people who are maybe slumbering, dozing off, loss of memory, So that really, really varies up to, a few cases that have developed maybe hypertension, and others who are not able to recover the weight that they lost during COVID-19 infection. So there's so many signs and that are related to post-COVID condition, but research is still going on. And I hope that at some point, when we are going to have many studies published in peer-reviewed journals, we'll be able to make also meta-analysis and be able to synthesize, that information to inform the population. Thank you.
Thank you very much, panelists. Back to you, Wayne.
Thank you, Tole and everyone. We always run out of time. We never there's so much information, and we have limited time, but we did get through quite a bit of information today, which was really helpful. I'd like to thank everybody who attended today, and want to let you know that we have recorded this dialogue, and we will send the recording link to everybody who joined this call today. And of course, as always, we'd love to hear from you about how you use this information in your reporting, and also hear from you about ideas for future media dialogues. And I think for now, I'll say thanks to Elsa Maria Karam, Dr. Michael Muteba, Dr. Felix Sani, and Ida Just. And until next time, for the Isar, our CCE Media Working Group and co-moderator, Tole Nyata,